that the varieties and the results that are obtained from the randomized observation study and the observational studies, they are having the much difference, and the observational study produces the much effective or the reproducible results or the considerable results. In 2007, several prominent medical researchers issued the strengthening the report of observational studies in epidemiology statement, in which they called for observational studies to conform to 22 criteria that would make their conclusion easier to understand and generalize. Next, coherent study. The term coherent is derived from the Latin word coheros. The Roman legiones were composed of 10 cohorts. During the battle, each cohort or the military unit consisting of a specific number of warriors and the commanding centurions were traceable. The word cohort has been adopted into the epidemiology to define a set of people followed over a period of time. The W.H. Frost, an epidemiologist who from the early 1900s was the first to use the word cohort in 1935 publication assessing the age-specific mortality rates and tuberculosis. The modern epidemiological definition of the word cohort means a group of people with the defined characteristics who are followed up to determine the incidence of or mortality from specific disease, all cause of death and some other outcome. The study design. A designed coherent study can provide the powerful result. In a coherent study, an outcome or the disease-free study population, it is first identified by the exposure or the event of interest and followed in time until the disease or the outcome of interest occurs. Because the exposure is identified before the outcome, coherent study have the temporal framework to assess causality and thus have the potential to provide the strongest scientific evidence. And the advantages and the disadvantages of this coherent study are, particularly it is advantages for examining the rare exposures because the subjects are selected by their exposure status. First their exposure condition that is determined, and then the particular subjects are selected because the multiple outcomes that can be examined simultaneously. And the disadvantage of this coherent study are it includes the need for the large sample size and the potentially long follow-up duration of the study design, resulting in a costly endeavor. And the coherent study, they can be prospective or the retrospective. Prospective studies, they are carried out from the present time to the future because the prospective studies are designed with specific data collection method, and it has the advantages of being tailored to collect specific exposure data and may be more complete. And the disadvantages of this prospective coherent study may be the long follow-up period while the waiting for event or the disease to occur. Thus, this study design is ineffective for investigating the disease with the long latency period and is vulnerable to a high loss to follow-up rates. Although the prospective coherent study are invaluable as examined by the landmark Fragment Heart study started in 1948 and still ongoing in the plastic surgery literature, this study design is generally seen to be ineffective and impractical. Instead, the retrospective coherent study are better indicated given the timeless and inexpensive nature of the study design. Retrospective coherent study, they are also known as the historical coherent study, and they are carried out at the present time and look to the past to examine medical event or the outcomes. In other words, a coherent study of the subject selected based on the exposure status is chosen at the present time, and the outcome data, that is the disease status or the event status which was measured in the past, are reconstructed for the analysis. The primary disadvantages of this study is the limited control the investigator has over the data collection, and the existing data may be incomplete, inaccurate or inconsistently measured between the subject. However, because of the immediate availability of the data, this study design is comparatively less costly and shorter than the prospective coherent studies. In case of prospective, based upon the present disease conditions, what are the future probable outcomes that can be faced. They are designed and they are studied for the long range period. And the main disadvantages is the long term study, and it can be incomplete because when does it stop, it doesn't know. Whereas in case of the retrospective, based upon the present disease, what are the probable similar diseases that has been occurred in the past, they are compared. In this, the previous or the before occur or the past occur disease condition, it is recreated. But so it has occurred in the past, the proper featured condition of the disease that can be customized to the present study. Hence it is a less cost effective treatment when compared to prospective. And the methodological issues. Selection of the subject in the coherent study. The hallmark of the coherent study is defining the selected group of subject by exposure status at the start of the investigation. And the critical characteristic of the subject selection is to have both the exposed and the unexposed group be selected from the same source population. With the same source population, both the exposed and the unexposed groups of people, they should be selected. Subjects who are not at a risk for developing the outcome should be excluded from the study. And the source population is determined by practical consideration such as sampling. Subjects may be effectively sampled from the hospital, be members of the community, or from the doctor's individual practice, and the subset of these subjects will be eligible for the study. What are the attrition bias or the low to follow bias or the errors are? Because the prospective cohort study may require the long follow-up period, and it is important to minimize the loss to follow-up. The loss to follow-up is a situation in which the investigator loses the contact with the subject, resulting in the missing data. If too many subjects are lost to follow-up, the internal validity of the study is reduced. And the general rule of the thumb requires that the loss to follow-up rate not exceed 20% of the sample. Any systemic differences related to outcome or the exposure of the risk factors between those who drop out and those who stay in the study must be examined, if the possible, by comparing the individual who remain in the study and those who are lost to follow-up or dropped out. And next is the case control study. The case control study were historically born out of interest in disease etiology, and the conceptual basis of these case control study is similar to taking a history and a physical. The deceased patient is questioned and examined, and elements of this history taking are knitted together to reveal the characteristics or the factors that predisposed the patient to the disease. First, the subject that is selected and his histological and the physical behavioral condition that is recorded or undertaken in order to determine the possible risk factor of the disease. In fact, the practice of interviewing the patient about the behavior and the condition preceding the illness dates back to the Hippocrates rating of the 4th century BC, and the reasons of practicality and the feasibility inherent in the study design typically dictates whether the coherent study or a case control study is appropriate. Based upon the interviewing the patient and his behavior and the histological condition, one can come to the conclusion that whether the coherent study should be carried out or the case control study. And this study design was first recognized in the Janet Land Claiborne study of breast cancer in 1926, revealing the finding that low fertility rate raises the risk of breast cancer. In the ensuing decades, the case control study methodology crystallized with the landmark publication linking smoking and the lung cancer in the 1950s. Since that time, the retrospective case control study have become more prominent in the biomedical literature with the more rigorous methodological advances in the design, execution, and the analysis. The study design. The case control study, they identify the subject by outcome status at the outset of the investigation. Here, the subjects are selected based upon the outcome they obtain. From them, the outcomes are obtained. Outcome of interest may be whether the subject has undergone the specific type of surgery, experienced a complication, or is diagnosed with a disease. Once outcome is identified and the subjects are categorized as a case and the control, and based upon these observational studies, that is the some of the group they are considered as a case, that is they are with a greater background of the disease condition, and some of them with a less history of the disease condition, they are considered as a control. Data about the exposure to the risk factor or the several risk factors are then collected retrospectively, typically by interview, abstraction from the records, or the survey. The case control study are well suited to investigate the rare outcome or the outcome with a long potency. This is one of the major differences between the coherent and the case control, but this is more appropriate for the long-term study compared with the case coherent study, because the subjects are selected from the outset by their outcome status. And thus, in a comparison to the coherent study, case control study are quick, relatively inexpensive to implement, require comparatively fewer subjects, and allow for multiple exposure or the risk factor to be assessed for one outcome. And the selection of cases. Sampling in the case control study design begins with selecting the cases. First step is the selection of the cases. In a case control study, it is imperative that the investigator has explicitly defined inclusion and the exclusion criteria prior to the selection of cases. For the selection of cases, these are the undertaking criteria that should be present. They are first determined, and based upon which the inclusion and the exclusion criteria are the outer wages that are also considered. For example, if the outcome is having a disease, specific diagnostic criteria and the disease subtype, stage of disease, or the degree of severity should be defined. Such criteria ensures that all the cases are homogeneous, such that all these criteria they are selected because the subject or the case or the control they are categorized or grouped, it should be homogeneous. Second, the cases may be selected from the variety of sources, including the hospital patient, clinic patients, or the community subject, but they belong to the same single population. Many community maintain the registries of the patient with a certain disease and can serve as a valuable source of cases. Their history background or the valid medical report, they can serve as a valuable source of cases. However, despite the methodological convenience of this method, validity issues may arise. For example, if the case are selected from one hospital, identified risk factor may be unique to that single hospital. This methodological choice may weaken the generalizability of the study finding. And after the finding of the study, next is the matching, whether the included under the certain required condition. Matching is a method that is used in an attempt to ensure the comparability between the cases and the control and reduce the variability and the systemic differences due to the background variables that are not of interest to the investigator. Each case is typically individually paired with the control subject with respect to the background variables. Based upon the background variables of the respective case and the control people, they are grouped, and the exposure to the risk factor of interest is then compared between the case and the control. Once they are grouped based upon the historical and the background condition about for the specific disease, their benefit to the risk factor they are compared. This matching strategy is called individual matching. The age, sex, and the race are often used to match the cases and the controls because they are typically strong co-founders of the disease. The co-founders are the variables associated with the risk factor and may potentially be a cause of the risk factor. And the multiple controls, and the investigator examining the rare outcomes may have the limited number of cases to select from, whereas the source population from which the control can be selected is much larger. In such scenarios, the study may be able to provide more information if multiple control per se are selected, and this method increases the statistical power. This is about the summarized form of the conclusion, that is The investigator planning an observational study can certainly use the STROBE statement as a tool to outline the key features of the study as well as coming back to it again at the end to enhance the transparency in the methodology reporting. Based upon the observation, they will be reported. Thank you. These are the references which have been used, that is the article and the wiki.